Hi, I'm so delighted to meet you in the 18th session of JIP Academy Diabetes. Let us move to the case study. 58 years old male patient, a known type 2 diabetes mellitus for past 5 years, hypertension for past 3 years, has following glycemic and lipid profile. His BMI is quite high, his blood pressure is on the higher side, definitely his glycemic profile is very poor, and there is an increase in albumin creatine ratio, and urea creatine is slightly on the higher side, 1.2. Lipid profile, there is a gross elevation of triglyceride. The ultrasound abdomen shows grade 2 fatty liver, and ECG and echo turned out to be normal. So what patient is on, we will see. Patient is on tablet glimepiride 1 milligram twice daily and metformin 500 milligram. So how will you manage? Okay. So any patient who presents with glycemic and lipid profile, better to you just start with his phenotype, whether he is under optimal weight or patient is overweight and obesity. His BMI is 28.9. So many of the time we fail to appreciate the importance of BMI. You know very well that when BMI goes up, then definitely the cardiovascular complication goes up. That's everybody is aware that. As compared to Western counterpart, at any point of BMI, our Indian population suffer more cardiovascular complication. That's why our threshold has been set little bit lower as compared to Western counterpart. For us, more than 23 of BMI, if BMI is more than 23, we consider our Indian population is at overweight. If it is more than 25, we consider they fall under the category of obese. On the other hand, in the Western counterpart, the cutoff value for the overweight is 25. For us, overweight is 23. So that subtle difference you have to appreciate. Then, his blood pressure is around 150 by 100. So any diabetic patient, who presents with elevated blood pressure, so what are the choices? So basically, we have three choices. One is calcium channel blocker and AC inhibitor or ARB, and you have thiazide diuretic. These are the three choices we have. But when it comes to diabetic patient, if they don't have any renal issues, if they don't have any cardiac problem, then the choice would be open. I mean, either you can choose calcium channel blocker or you can use ARB or AC inhibitor. But any diabetic patient who has microalbuminuria or macroalbuminuria or some form of chronic kidney disease, these patients deserve ARB or AC inhibitor than calcium channel blocker. That's very, very important. So, someone with diabetes, if they present with hypertension, you have to explore whether the patient has any form of nephropathy. So, these patients should be ordered one albumin creatinine ratio. In that way, this patient has undergone albumin creatinine ratio that is normal is 30 milligram per gram. So this patient has 67. That means the patient has albuminuria. Before you conclude that albuminuria at very first visit, they say this urine albumin creatinine ratio should be repeated 2 or 3 times within 3 months. They should show the consistent elevation of albumin creatinine ratio. Then you can label that patient has nephropathy. Then there are some causes which can produce albuminuria. For example, even urinary tract infection. Even the drugs can produce proteinuria. Even long standing can produce proteinuria. Severe form of exercise can produce transient proteinuria. So these are the even cardiac failure. So these are the causes to be excluded. Then if you think that the consistent elevation of albumin creatinine ratio 2 to 3 times within 3 months after excluding the other causes, then the patient has entered into the stage of nephropathy. So these patients deserve ARB or ACE inhibitor rather than calcium channel blocker, because ACE inhibitor, ARB are capable of reducing, okay, or retarding the progression of albuminuria as compared to calcium channel blocker. Even it can retard the progression of chronic kidney disease also. So this patient, okay, if they have consistent elevation of blood pressure, this albuminuria, this patient definitely deserves telmisartan 40 milligram daily once. So this is my opinion. And this patient has undergone urea creatinine as well. But here the patient has undergone albumin creatinine ratio and this patient has creatinine 1.2. Don't be content with simple blood urea creatinine. So all the patients should undergo EGFR. So what is the importance of EGFR? One lean person, okay, creatinine 1.2. So probably 40 kg male with lean body mass, creatinine 1.1 or 1. So when you look at creatinine 1.1, so you may easily say that, so probably creatinine within normal limit. So, but parallelly they may have reduced renal function. So when you have reduced renal function because of lean body mass, your creatinine may not be high, but never indicates that the patient has normal renal function, because your creatinine is produced from the muscle. So creatinine is produced from the substance called creatine that is present in the muscle. For example, I have lean body mass, okay. When you have lean body mass, your creatinine production from the muscle would be low, okay. Creatinine production would be low. So what happened? Naturally you will have decreased creatinine value because of your lean body mass. So when your kidney function is impaired, correspondingly your creatinine may not be high because of your lean body mass. So any lean body mass can influence your creatinine value. That's the reason we refer EGFR. For example, another example, one adult male, okay, with good muscle mass, okay, heavy muscle mass, he may have creatinine level 1.3. When you look at creatinine 1.3, you may think that the patient has suffered renal function. But what you have to understand, this increased creatinine is not due to impaired renal function, it is due to overproduction of creatinine from his huge muscle mass. So this can be only differentiated by your glomerular filtration rate. So even the age, when you have advanced age, so what happened? Your body mass will be lean. So naturally your creatinine will be low, but all old age people, your GFR may be high. So what I would like to insist that, don't be convinced with simple urea creatinine. When you have creatinine 1.1, but 1.1 or even 1 milligram, but GFR will be very low, suggestive of kidney disease. When you have creatinine 1.3, you may be tempted to say that he has some kidney problem. But if you do EGFR may be normal, more than 90. So what I am trying to say, always do EGFR. Don't be convinced with blood urea creatinine alone. So this patient is supposed to undergo one EGFR because his creatinine is somewhere around at high normal value. Okay. Then we are coming to fasting postprandial management. So this patient is already on glimepiride and metformin. So what are the options we have available? So as I told you earlier, nowadays the usage of glimepiride has been pushed down because couple of the reasons. One, glimepiride extracts insulin, okay, it inhibits potassium channel in the pancreatic beta cells. When closure of potassium channel occurs, you have depolarization of the cells. So calcium entry occurs, then the granules of insulin will be released. That is a one mechanism. Okay. So ultimately sulfonylurea releases the insulin, by which it reduces the sugar level. When the drugs which releases the insulin, the problem is whether you eat or not, it continues to act. So hypoglycemia is very common. It releases insulin irrespective of your glucose level, when it comes to action of sulfonylurea. So when enormous amount of insulin is disproportionate amount of insulin is released from the beta cells, what happened? Insulin is an anabolic hormone. Okay, so what happened? It will promote the lipid storage in the adipose tissue. It promotes the storage of protein. It promotes the storage of glucose. So since it is an anabolic hormone, your weight gain. So you will gain weight. So the most important consequence of the sulfonylurea is one, the hypoglycemia and weight gain, which is not at all warranted in diabetic patient, because any recurrent hypoglycemia that can induce sudden onset of cardiovascular complication, because these patients when they develop hypoglycemia, so you will have increased sympathomimetic activity. When they develop tachycardia, they already tightened atherosclerotic cardiovascular which they harbor. So there may be insufficient blood supply to the heart because of tachycardia. When you have very normal life, okay, so you may not require abundant blood supply. When you have tachycardia, you require abundant blood supply. So what happened? There will be less demand. So I mean there will be more demand but less supply, resulting in acute coronary syndrome. So hypoglycemia can produce more snacking. So again weight gain. So when you gain weight, what happened? Weight gain will offset the beneficial effects of normal glycemia. So that's why we don't prefer glimepiride nowadays. So already the patient is on glimepiride 2 mg. So when you take sulfonylurea, you have two generation. First generation, I think that chlorpropamide, tolbutamide, even we have not used so far. The second generation of sulfonylurea, then you have 4 drugs. One is glyburide, or otherwise called glibenclamide. The glibenclamide is available everywhere. Usually it is commonly used in in primary health centers. And the glimepiride and the glycoside, and you have glipizide. Just I want to give some few peculiar features of this sulfonylureas. When you take glibenclamide, that's a brand name is Dioneal. Glibenclamide is considered as a long-acting sulfonylurea. So it can produce hypoglycemia aggressively. That's why glimepiride should be avoided. Glibenclamide produces recurrent hypoglycemia because of its potency and long duration of action. So glibenclamide should be avoided in elderly, frail patient. And second one, when someone has the tendency to skip the meal, if you administer glibenclamide, then probably more hypoglycemia occurs. And when someone has chronic kidney disease, irrespective of the stage, you avoid glibenclamide. And on the other hand, we commonly employ glimepiride. They have intermediate action. Still hypoglycemia is possible. But the biggest advantage of glimepiride is it's a daily once. You can use daily once, but we are using twice daily as well. So glimepiride has good amount of long-acting action. So that is the biggest advantage. Still, it is capable of producing moderate hypoglycemia. Glimepiride can be given daily once. It can be given up to 8 mg, but of the maximal dose would be better. So we limit ourselves to only 4 mg glimepiride. Then when it comes to glipizide, that's a famous brand name is Glyinase. Glipizide we can give 5 mg thrice daily. It's very short acting. If at all you are forced to give one sulfonylurea in CKD patient, then you prefer glipizide. So glipizide can be given, maybe the choice of sulfonylurea in CKD patient, but generally in any CKD patient, do EGFR. If EGFR less than 30, try to avoid OHA, go for insulin, or any CKD patient, the best oral hypoglycemic drug is DP4 inhibitor, the only DP4 inhibitor, that is linagliptin. I have insisted many times. Linagliptin 5 mg can be given any stage of CKD patient, even the CKD patient who is on dialysis as well. Okay. So glipizide can be given in CKD patient, but it should be given thrice daily because short acting. And glycoside. So glycoside you can give 240 mg per day. Commonly we employ 80 mg glycoside. So the advantage of glycoside is it is less capable of producing hypoglycemia. They say that glycoside has some antiplatelet action. It can reduce the oxidative stress. So many of the clinical practitioners, they prefer glycoside over glimepiride, which is extensively used. So this is a one small brief summary of the glimepiride. So I mean sulfonylurea. So already patient is on glimepiride 2 milligram. So now you have to reduce fasting and postprandial. As I told you earlier, always target fasting. Okay, always target fasting first. That means if you want to target fasting, then you have to introduce or you have to escalate the dose in the night. Already patient is on glimepiride and metformin. If you want to increase glimepiride, then probably you can increase glimepiride in the night 2 milligram. But when you increase glimepiride, the chances of hypoglycemia, especially nocturnal hypoglycemia, is more than if you want to use the drug which may not produce hypoglycemia. I could say SGLT2 inhibitor, but if you introduce SGLT2 inhibitor in the night, that will cause urinary frequency. Metformin patient has taken 500 milligram twice daily, then probably metformin can be given up to 1500 milligram. Normally up to 2650 milligram can be given. So probably you have one more option, to escalate metformin in the night. Probably metformin from 500 to 1000 milligram can be given. So if you introduce 500 milligram in the night, probably another 40 to 50 milligram can be reduced. Still you have another fasting is 140 despite introduction of what? Metformin. Then probably you can introduce one DP4 inhibitor considering the creatinine 1.2. Okay, if GFR is a little bit less, then probably you can introduce linagliptin. 5 milligram in the night. So best choice can be linagliptin and metformin in the night. That can reduce your sugar level from 190 to 120. So this fasting is over. Then postprandial. So again postprandial patient is on glimepiride and metformin 1 milligram. Either you can escalate glimepiride even another 2 to 3 milligram, or you have options. Okay, what are the options you have? Already we have introduced D4 inhibitor in the night. Then probably you have options of SGLT2 inhibitor. I prefer SGLT2 inhibitor in this patient for two reasons. One, patient has obese. Okay, SGLT2 inhibitor can produce modest weight reduction. Okay, by 3 to 4 kg. When you lose the weight, this fatty liver can be reversed. So they say fatty liver can be reversed if you shed weight by 5%. Even if you reverse your weight gain by 10% from your baseline, even it can reverse the fibrosis that is present in the fatty liver. So weight reduction is at the most important. Even escalating glimepiride in this patient, I think that considering weight, already he is under obesity as per our guidelines, Indian guidelines. So I don't want to make him more obese. So probably you can retain glimepiride same 1 milligram on both the sides, because removal of glimepiride sometimes what happens, sudden surge in sugar level. So instead of escalating glimepiride in this patient, so we have introduced linagliptin with metformin in the night, and you introduce SGLT2 inhibitor in the morning. So probably I could say dapagliflozin or empagliflozin. If you introduce dapagliflozin, it can produce modest weight reduction, at least 2 kg weight loss. It can reduce the intensity of the fatty deposition in the liver too. And third one, patient has microalbuminuria. So SGLT2 inhibitor is capable of reducing albuminuria. It can reduce the progression of CKD. So it's very ideal choice. And moreover, very, very important is any patient who has consistent microalbuminuria, they are very prone for cardiovascular complication. They may go for any time, sudden acute coronary syndrome. So this patient definitely deserve SGLT2 inhibitor because of albuminuria and obesity. This albuminuria can lead to cardiovascular complication because fatty liver, any patient who harbor fatty liver, they are prone for cardiovascular complication. Obesity poses a big threat for inducing cardiovascular complication. Albuminuria, it's one of the risk factor for cardiovascular complication. Because of all these reasons, SGLT2 inhibitor, if you introduce, definitely that can reduce your cardiovascular complication. That's very, very important. When you have albuminuria, consistent albuminuria, considering the prospects of getting cardiovascular complication, I would like to introduce one atorvastatin 10 milligram, irrespective of lipid profile. I would like to introduce aspirin. Any patient who presents with obesity, microalbuminuria, hypertension, even in the absence of existing cardiovascular disease, you can introduce this patient deserve aspirin and atorvastatin. Okay, now postprandial I have introduced DAPA, but DAPA is able to produce sugar level from 280 to probably 240, something like that. Then you can so you are forced to introduce some more medication to reduce. Okay, when patient denies the administration of insulin, then probably the thing is pioglitazone. But when you say pioglitazone can produce weight gain, but this mechanism definitely will be helpful for this patient. In the next session, we will see how pioglitazone would be helpful in this patient, and we have a lot more to explore the things in this case study. I think that you have immensely benefited. Once again, I would like to thank each one of you.